Hello guys, welcome back to another lecture of radiology. So today we are going to discuss the imaging features of various congenital heart diseases, right? So guys, most of the questions that will be asked will be on your cyanotic heart diseases, right? And what are the important cyanotic heart diseases that you are aware of, right? So these include your tetralogy of Fallot. Then you have transposition of great arteries, right? Then we have your Epstein anomaly that we are going to study today, Epstein anomaly, and we are going to study the imaging features of TAPVC, right? So these are the important congenital heart diseases with which you should be aware about the imaging features. Okay. So let us begin with the first image. Guys, what do you see in the first image? Right? So in the first image, if you look at the mediastinum, there is narrowing of the superior mediastinum. And we can see that the heart is enlarged, and it looks like as if an egg is lying on the string. Okay, it looks like as if an egg is lying on the string. So guys, this is the characteristic egg on side appearance that is seen in patients with transposition of great arteries, right? So guys, it is the most common congenital heart diseases, right? And it is most common in infants born to the diabetic mothers, right? So guys, you must have heard about that there are two types of TGA. So what is happening in transposition of great arteries? Is that your aorta, which normally arises from the left ventricle, it is arising from the right ventricle, right? So the blood from the SVC, it is going into the IVC. Then it is directly going into the blood from the SVC, it is going into the right atrium, then your right ventricle, and after that it is going into the aorta. Okay, so basically aorta is receiving deoxygenated blood of the right ventricle, and that is why, guys, it is a cyanotic heart disease. Aorta is receiving your deoxygenated blood from the right ventricle. And what is happening? Pulmonary veins, they are going into the left atrium, left ventricle, and from the left ventricle what we are getting? We are getting your pulmonary artery. So guys, you are seeing that there is no mixing of oxygenated and deoxygenated blood. So if these babies need to stay alive, there should be some mixing of oxygenated and deoxygenated blood, right? So guys, how is this mixing occurring? So just remember that these patients of transposition of great arteries, these are always associated with some atrial septal defects, atrial and ventricular septal defects. Okay, so there is always some atrial and ventricular septal defect that is seen in these patients, because of which these patients can stay alive, right? So this is one point. Now guys, you must have heard about that there is one more thing, that is your corrected TGA, and there is one uncorrected TGA. So there are two types of TGA that you guys must have heard of. Okay, so this corrected TGA, this will present in the adults, and this will present in the uncorrected TGA will present in the newborns. So let me explain you what is happening in corrected TGA. The thing that we studied, okay, your SVC draining into the right atrium draining into the right ventricle, and right ventricle it is giving rise to the aorta. Okay, this is basically your uncorrected TGA. Okay, so what is happening in the corrected TGA? In the corrected TGA, aorta is arising from the right ventricle. Okay, so when the right ventricle is not giving rise to the pulmonary artery, okay, we call it as ventriculo-arterial discordance. Right? So aorta will arise from the right ventricle, okay, but what will open into the right ventricle? Okay, so here in patients with corrected TGA, you will see that your left atrium, which is receiving oxygenated blood from pulmonary veins, these are going to open into the right ventricle. So basically in these patients you will find that from the right ventricle aorta is rising, but right ventricle is receiving oxygenated blood from the left atrium. That is why these patients will not present during the birth. These will present in the adult age group. So besides ventricular-arterial discordance, you will also see these patients also have atrioventricular discordance. Right? So this is what you mean by corrected TGA and uncorrected TGA, right? So why is superior mediastinum shortening happening, right? So guys, if you will look at the mediastinum, normally what happens, aorta is lying posterior and to the right of pulmonary artery. But in patients with TGA, transposition of great arteries, you will see that aorta it will lie, okay? So this pulmonary artery and aorta, these will lie in the straight line. Okay? So aorta and pulmonary artery, they are lying just anterior and posterior to each other. These are not lying side by side to each other. So because of this, what happens? There is narrowing of the superior mediastinum. Okay? And one more point that you should be aware is that because you will also see dilatation of right atrium and right ventricle in these patients. Okay, you will also see dilatation of right atrium and right ventricle in these patients. Why? Because guys, if the right ventricle has to pump blood to the pulmonary arteries, okay, it will not require much force. But if the right ventricle, guys, it is pumping blood to the aorta, right ventricle is pumping blood to the aorta. Okay? So what will happen in that case? It will require more muscle, more power, right? And because of this, you are going to find right ventricular dilatation as well as hypertrophy in these patients. Okay, and we are going to see as we move forward how does right ventricular hypertrophy looks like on X-ray, right? We are going to see how does right ventricular hypertrophy looks like on X-ray, right? So moving on to the next X-ray. Guys, what are we able to see on this X-ray? So we are seeing in the previous X-ray, we were seeing that the mediastinum was narrowed. But in this X-ray, if you look at the superior mediastinum, okay, there is widening of the superior mediastinum. Right? So guys, the patient has history of cyanosis, and this is the characteristic snowman appearance. And this snowman appearance, guys, it is seen in patients with TAPVC. And what does TAPVC stand for? It stands for total anomalous pulmonary venous connection. So what do you understand by anomalous pulmonary venous connection? So guys, what is happening? Pulmonary veins, where are they normally draining into? Pulmonary veins, they drain into the left atrium, right? Right atrium will receive your SVC and IVC, and your left atrium, it will receive your pulmonary veins. And how many pulmonary veins are there? There are 4 pulmonary veins. So in a normal patient, these pulmonary veins, these will drain into the left atrium. So when these pulmonary veins, these are draining into the right atrium. When these are draining into the right atrium, we will call it as a case of total anomalous pulmonary venous connection. Now what is happening? What is the problem with TAPVC? What is the problem? So guys, pulmonary veins, these bring oxygenated blood from the lungs into the left atrium. So when this oxygenated blood is not going into the left ventricle, it is not going into the aorta, it is not going into the aorta, it is in that case that the child, it will present with cyanosis. It will present with cyanosis. ठीक है, it will present with cyanosis, right? So again, if the child has to stay alive, there has to be mixing of some blood. So imagine this is your right atrium, ठीक है, right ventricle, left atrium, left ventricle. All the pulmonary veins, these are draining into the right atrium. Now your left ventricle, it is not receiving any oxygenated blood. So guys, if the child has to stay alive, there has to be some defects in the atrium. Interatrial septal defect can be there, or there can be some defects in the ventricle. So just remember this TAPVC will again be associated with some defects in the atrial septum or ventricular septum, ASD or VSD, right? So now you guys understand. So our body is very intelligent. So if there is no mixing of oxygenated and deoxygenated blood, so in order to keep the baby alive, these septal defects will be present in that baby. Okay, so that there is some mixing of the oxygenated and deoxygenated blood, and your child can stay alive, right? So this is what is your TAPVC. Now another thing that you are going to see in TAPVC is that, one more thing. So these pulmonary veins, these four pulmonary veins, these will join to form one single vein, one common vein. This will join to form one common vein, right? So when they are joining to form one common vein, and this one common vein, it can drain into the SVC, okay? Then it can drain into the IVC, and it can also drain directly into the right atrium, okay? It can also drain into the right atrium, okay? So when your common vertical vein, it is draining into the SVC, it is known as supracardiac type of SVC. Right? When all the pulmonary veins, these are joining to form a single vein and they are draining into the SVC, it is known as type 1 or supracardiac SVC, and this is the most common type of SVC. In the second part, it is cardiac type of SVC. In this, all the veins, these are either draining into the right atrium or they are draining into the coronary sinus. ठीक है? And type 3 में क्या है? These are draining into the IVC. And in type 4, it is a mixed type. In which the veins can either drain into the SVC, IVC. Okay, so it will be a mixed type. Guys, because this right-sided heart, it is receiving blood from the whole body through the SVC and IVC. It is receiving blood from the lungs. Because so much blood is flowing into the right side of the heart. Okay, it will again result in dilatation of. It will again be associated with dilatation of right atrium and right ventricle. Okay, so this is a common sense. This is the common sense thing that you guys should be aware of. Right? So guys, if you look at this X-ray, this X-ray, this is known as snowman appearance. It is shown by type 1 supracardiac type of SVC. And what will happen? Just remember that this right border of the superior mediastinum, it will be formed by your SVC, and the left border, it will be formed by the anomalous. It will be formed by the common vertical vein. Right? So guys, this was all about TAPVC, right? And there is one more condition, TAPVC. So instead of T, what we will write PAPVC. PAPVC stands for partial anomalous pulmonary venous connection. Partial anomalous pulmonary venous connection. So in this case, what will happen? That your pulmonary vein, single pulmonary vein or two pulmonary veins, not all the pulmonary veins, but single or two pulmonary veins. These are going to drain into the right atrium. Right? Or even SVC. So this is an X-ray. This is a characteristic X-ray that you guys should be aware of. That is where you are seeing a linear shadow, a linear radiopacity can be seen. So this radiopacity it is formed by the anomalous pulmonary vein. Okay, that is draining into the IVC. It is also known as Schmitar vein. Right? So basically there is some anomalous pulmonary vein, that is your inferior pulmonary vein, right inferior pulmonary vein. Okay? It will drain into the IVC, and it is going to give an appearance that will resemble a Turkish sword. Okay? That will resemble a Turkish sword, and this Turkish sword is known as Schmitar. That is why this is also known as Schmitar sign. So what is happening in Schmitar sign? You will see a linear echogenic shadow along the right heart border. That is the shadow of the right inferior pulmonary vein draining the right lower lobe of the lung. Okay? So this is also associated with hypoplasia of right lung. Hypoplasia of right lung and anomalous arterial supply of the right lung. That is from the aorta. Okay, that is from the aorta. And when this Schmitar vein, it is associated with these features: hypoplasia of right lung, anomalous arterial supply of right lung from the branches of the aorta. All these features, these are together known as Schmitar syndrome. So just remember this Schmitar syndrome, it is associated with partial anomalous pulmonary venous drainage, where your right inferior pulmonary vein, it is draining into the IVC. So guys, there is one more. Let me draw an heart for you. Okay, so this is your heart. So sometimes what happens, in our body, all the structures on the left side of the body, they are going to resemble the structures on the right side of the body. Just listen to me very carefully. Okay, so the structures on the right side of the body, they are going to resemble the structures on the left side of the body. Okay, the structures on the right, they are going to form a mirror image of the structures on the right side of the body. So guys, this condition is known as left-sided isomerism. The structures on the right side of the body, they are going to resemble the structures on the left side of the body. So why I am teaching you this? Because this is again associated with PAPVC. So what happens if you look at the atrium? So if left atrium has two pulmonary veins, okay, your right pulmonary veins will also have two pulmonary veins draining into it. And this is known as PAPVC. What else can we see? We can also see that liver will be present in the midline. Okay? Stomach will be present on right side of the body, and you will see multiple spleens. Okay, multiple spleens will be present on right side of the body. So this is known as polysplenia. So what happens? The spleen will be seen on the right side of the body. The spleen will be seen on the right side of the body, and these spleen, these will try to take the appearance of liver. Liver has two lobes. Okay, so here, here in this case, what happens? The spleen, it also tries to take multiple lobes. It also tries to take the appearance of multiple lobes, and this is known as polysplenia. So guys, if a question comes on left-sided isomerism, what will be present? You can see polysplenia, right? You can see PAPVC. What else? On left side, there are two lobes of the lung. Okay, so in left-sided isomerism, you will also see bilobed lungs. Bilobed lungs. Even on right side, you will see two lobes of the lung. You will see two lobes of the lung. Okay, so left-sided isomerism, PAPVC, bilobed lungs. Okay, polysplenia, liver is in the midline. Liver is in the midline. Okay, and one more feature that you can see is that IVC will be interrupted. IVC will be interrupted, right? So this is one more feature that you can see in patients with left-sided isomerism. Left-sided isomerism. So what do you mean by interrupted IVC? Normally, IVC is going to carry blood. IVC is going to carry blood from the lower half of the body. Lower half of the body. So in case with interrupted IVC, your IVC is just formed by the hepatic veins, and the blood from the lower half of the body, it is carried by the hemiazygous vein. It is carried by the hemiazygous veins. So you don't need to go into too much depth. Just remember that interrupted IVC, bilobed lungs, PAPVC, then your polysplenia, all these are features associated with left-sided isomerism. Left-sided isomerism. So in second most common congenital heart diseases, patient again presents with cyanosis. You see a boot-shaped heart. Boot-shaped heart. So boot-shaped heart, guys, it is seen in patients with tetralogy of Fallot. Tetralogy of Fallot, right? So this boot-shaped heart is seen in patient with tetralogy of Fallot. And what are the four features? What are the four features that you are going to see in these patients? The four features that you are going to see is that you will see infundibular stenosis. Infundibular means the right ventricular outflow tract from where your pulmonary artery is coming. Okay, so the region of pulmonary artery, the tract of origin of pulmonary artery, that will be stenosed. Okay, so what will happen? Because of the narrowing of the infundibulum, because of the narrowing of the origin of the main pulmonary artery. Okay, blood will not go into the lungs. It will not get oxygenated. Just listen to me very carefully. When there will be infundibular stenosis, not enough blood is going into the lungs. And that is why this child presents with cyanosis. ठीक है ना? Clear? So we should also understand why are these babies presenting with cyanosis. ठीक है? And because less blood is going into the lungs, the chest fields appear relatively black. And this is known as pulmonary oligemia. Okay? So we are having infundibular stenosis, right? Just remember, guys, whenever the heart has to pump blood against the resistance, whether it is aortic stenosis, whether it is pulmonic stenosis. So in pulmonic stenosis, your right ventricle is pushing the blood against the pulmonary artery. So in that case, when it is applying more force, what will happen? It will result in hypertrophy. Okay, when you are picking more weights in the gym, what will happen? There is hypertrophy of the muscles. So when even the heart, it is pumping blood against some resistance, against some more force. In that case, what happens? In that case, there is hypertrophy of the muscle. So you are going to see right ventricular hypertrophy. The third thing that you are going to see in these patients is overriding of aorta. So what do you understand by overriding of aorta? I am going to explain you what you understand by overriding of aorta. And the fourth thing that you are going to see, it is ventricular septal defect. Okay? So guys, what happens? If this is your heart, let me draw the ventricles for you. Okay, just remember this is your right ventricle and this is your left ventricle. This is your left ventricle. So what will happen? What will happen in these patients? There will be defect. There will be defect in the ventricular septum. This is known as VS3. This is known as VS3, and your aorta. And your aorta, it is going to arise from both the right and the left ventricle. It is going to arise from both the right and the left ventricle. So when aorta is arising from both the right and the left ventricle, this is known as overriding of aorta. This is known as overriding of aorta. Okay, so guys, one more thing that is going to add to your knowledge, that you are going to see in patients with tetralogy of Fallot. Tetralogy of Fallot, it is your MAPCAS. MAPCAS. So what does MAPCAS stand for? Okay, MAPCAS stands for major aortopulmonary collateral vessels. Okay, major aortopulmonary collateral channels, right? Because there is infundibular stenosis. So if this is your right ventricle, and this is from where the pulmonary artery is arising. Okay, so this is from where your pulmonary artery is arising. There is narrowing of the infundibulum. So this results in decreased blood to the MPA, RPA and LPA. So what happens? In order to compensate for the decreased blood to the lungs, there are collateral channels which are coming from the aorta. And they supply your hilum. They supply both of your hilum. So this way, these MAPCAS, these help the newborns to stay alive. There can be patent ductus arteriosus also. What is PDA? PDA are connection between the pulmonary artery and the arch of aorta. So with the help of PDA also, there is increased flow to the pulmonary vessels, which help the child to stay alive, right? So now coming to another case. So this patient has, history of weakness of the limbs, cramping sensation in the limbs. When you are measuring the BP of these patients, okay, there is unequal BP in both the right and the left arm. Okay, unequal BP is seen in the right and the left arm, or upper limb and the lower limb, right? So what are you going to think of? If you look at the X-ray of these patients, you are going to see that there is a figure of three appearance. There is a figure of three appearance which is seen in coarctation of aorta, right? So now let us understand what is happening in coarctation of aorta, right? So in coarctation of aorta, there will be narrowing in the arch of aorta. Because of the narrowing, the branches of the arch of aorta, they may receive normal blood supply. But the descending thoracic aorta, your abdominal aorta, it is going to receive decreased blood supply. So what is our body going to do? Our body is going to compensate for this. So how is the body going to compensate for this? Multiple collateral channels are going to develop. And what are these collateral channels? So guys, aorta gives branches such as your posterior intercostal artery. These posterior intercostal arteries, these anastomose with the anterior intercostal arteries. And this anterior intercostal artery, these are branches from the internal mammary artery. And internal mammary artery is further a branch of the subclavian artery. Okay? So what happens? These collaterals are going to form. And these collaterals, these are going to supply the descending thoracic aorta. Now because of these collaterals, these posterior intercostal arteries, this will get prominent. And because of the pulsations of the posterior intercostal arteries, which are traveling along the lower border of the ribs, they are going to cause remodeling of the lower border of the ribs. and because of this remodeling there will be inferior rib notching in these patients. Inferior rib notching can be seen in these patients, right? So we are understanding by this inferior rib notching present in this patient. So this is also known as Rosler sign. So inferior rib notching is there in this patient because there are collateral channels which are developing. Which are going to supply your descending aorta. ठीक है? Now I'm going to tell you one more interesting thing. अब हमें समझ आ गया कि collaterals के कारण rib notching हो रही है. There is inferior rib notching because of the collaterals. Now what happens? This narrowing that you are seeing in the coarctation of aorta, if it is occurring after the origin of the subclavian artery, then you will see bilateral rib notching. Why? Because both the subclavian artery, they will give rise to collaterals from the internal memory artery. For example, if this coarctation of aorta, it develops before the origin of the subclavian artery, before the origin of the left subclavian artery, ठीक है? अगर ये coarctation of aorta develops before the origin of the subclavian artery, then guys, can you tell me what is going to happen? Your left subclavian artery will have decreased blood supply. So if it is having decreased blood supply, do you think it will have the capacity to form collaterals? No friends, it is not going to form collaterals. ठीक है? So it will not form collaterals when it is having decreased blood supply. ठीक है? So in that case, what is going to happen? You will see rib notching. You will see only right-sided rib notching. ठीक है? Is that right? So when rib notching is present only on the right side, it means that there is preductal type of coarctation of aorta. Right? Now what happens? There is one more case we need to understand. If this coarctation of aorta, it is developing after the origin of the left subclavian. Artery, but there is a anomalous right subclavian artery. ठीक है? So there is an anomalous right subclavian artery. So in that case, what is going to happen? This anomalous right subclavian artery, it is going to have decreased blood supply. So in that case, rib notching will be present only on the left side. ठीक है? So just think about these conditions when you go before going to bed. ठीक है? Now last thing, the last X-ray that we are going to study, that is your box-shaped heart. So guys, just remember this box-shaped heart. It is seen in patients with Epstein anomaly. And what happens in Epstein anomaly? The tricuspid valves, these are inferiorly placed, and because of this, there is gross dilatation of the right atrium. And it is associated with lithium use during pregnancy. So guys, I hope you enjoyed this lecture of congenital heart diseases. You got to understand some more things beside the imaging features. So let me just summarize the imaging features which should be on your tips. So tetralogy of Fallot, you are going to see boot-shaped heart. Remember the 4 features and MAPCAS. MAPCAS is something that I told you which you guys must not be aware of. Okay? Then I told you about transposition of great arteries. In transposition of great arteries, I told you both about the corrected TGA and uncorrected TGA. Okay? So just remember that your corrected TGA, it will present in the adults. Then we discussed about the TAPVC, which was giving the characteristic snowman appearance. It is of various types, type 1, 2, 3, 4. Type 1 is the most common, and type 1 is going to give the it is going to give the snowman appearance. Then we discussed the Schmittard syndrome, which was associated with PAPVC. Okay, we discussed left-sided isomerism, and we discussed coarctation of aorta, how it resulted in inferior rib notching. Inferior rib notching is known as Rossler sign, and rib notching can be seen in both sides. It can be seen on right side, it can be seen on the left side. So just try to think about all these conditions. Till then, guys, bye bye. Take care. Keep working hard.